And hi there, I'm Dr. Jay Harness, and welcome to a delayed start, if you will, of our Google Hangout here at Breast Cancer Answers. You know, Wendy and Sarah, this darn technical stuff, where we've been sitting here for a half hour, and our staff's been running all over the place trying to get us actually out there live to be able to talk to people, and we're finally here. There was a point I thought, it's the stars are aligning against us. But anyway, we're finally here, and we welcome everybody to another live Google Hangout. Today we're going to be focusing on 3D mammography, and we're going to explain what that's all about. And it's a real privilege to introduce Dr. Sarah Friedewald from Park Ridge, Illinois. And she goes by Frida, but I'm going to call her Sarah because, Sarah, welcome to finally our delayed Breast Cancer Answers live Google Hangout. Please say hello.
Thank you so much. It's nice to be here.
And Sarah, by background, you're a radiologist, and it sounds like to me that you've had a primary focus on breast imaging. Is that correct?
Yes, I did specialized training, which is what we call a fellowship in breast imaging.
Well, wonderful. And we're going to get into your paper that was recently published in the Journal of the American Medical Association in just a minute. But to keep us honest, I have to introduce Wendy Hartley. Wendy is the delightful, beautiful wife of and a co-founder with myself and her husband, Todd Hartley, of Breast Cancer Answers. And very importantly, and to help keep us honest, is the fact that Wendy is also a breast cancer survivor. So Wendy, welcome to a live Google Hangout.
Thank you. Grateful to be here with the two of you.
Yeah. So Sarah, I was thrilled when I saw this article in JAMA talking about breast screening. I'm going to read the title now. Breast screening using tomosynthesis in combination with digital mammography. This is a retrospective study. Now, the majority of the people watching our Hangout have no clue what tomosynthesis is and what it's all about. So how do you explain that to your patients in layman's terms? What is tomosynthesis, or if you will, 3D mammography?
So tomosynthesis is really just a fancy term for 3D, which basically we take multiple low-dose images through the breast, similar to a mammogram, and we're able to see through that breast tissue page by page and detect more breast cancer.
In other words, it's still the same equipment, still the same mammo equipment, but it's been upgraded. And so like the pages of a book, I think you're describing it, instead of just taking one straight-on shot, is it taking multiple different shots as it goes through and then combining those, and then you as a radiologist sort of, if you will, leaf through the book?
Exactly. So women won't necessarily notice any difference between the examination. We actually do a combination of the 3D and the 2D mammogram. So the patient will be placed in compression just like a regular mammogram, and again, the machine moves across the breast and takes multiple low-dose pictures, and then we take at the very end of the examination, we take the 2D picture, or what everybody is used to.
Now, why are you combining both the 2D and the 3D? Obviously, you as a fellowship-trained breast radiologist is used to the 2D images. Does that help you with the orientation? And when the machine is moving across, probably the patient is not aware of that at all, correct?
They may notice that it moves a little bit, but it's not necessarily very obvious. And we need the 2D picture because it provides an overview. It's sort of like a map. And so we need to see what's going on in the entire breast, and then, or if you want to use the same analogy, look at the covers of the breast, and then we can page through inside and see what's going on inside.
Yep, terrific. So why has this technology been developed? I tell patients all the time that mammography, particularly digital mammography, and I think it's fair to say that digital mammography is now the standard of care for mammograms, but what led to the development of 3D?
Well, we're always trying to improve our technology and definitely trying to find the cancers that are out there that may have otherwise been not well visualized on the 2D mammogram. So mammography has some limitations, particularly in women with dense breasts. We have a hard time seeing through that breast tissue. So to use another analogy, it's if a woman has dense breasts, it's like having clouds in the sky, lots of clouds in the sky, and it's very hard to see an abnormal cloud through all of the other clouds. But if a woman has a fatty breast, then it's similar to a very bright sunny day, and to see an abnormal cloud is very easy. So we need to be able to see through that breast tissue.
So in other words, I love that analogy. I'm going to use that myself. That's absolutely fantastic. So when you're looking at the black and white mammogram images, fatty tissue is dark. It's black, if you will, in many cases. And breast tissue is white. And
Right.
cancers, at least by x-ray, is typically white.
Right.
So if you have white on white, as you say in your cloudy sky analogy, you wouldn't be able to see it. Is that a fair statement?
Absolutely. Actually, we really, as mammographers or breast imagers, we like fatty breasts because we're going to be able to see those abnormal clouds. So it is pretty tricky in women who have dense breasts. And so because mammography is not perfect, it's not a perfect examination, we need to be able to better characterize or better see some of those abnormal clouds. And so 3D was developed to try to see through some of that tissue.
Dr.
Okay,
Frida,
well,
can I intervene 1 second about dense breast? Because I wasn't educated that I had dense breast tissue until my mammogram showed up that they didn't show up that I had cancer, yet the ultrasound led to that we need to have a biopsy. Who is supposed to educate the patient? Is it supposed to be the OBGYN? Is it the radiologist? Is it the person that's taking the tech that's doing the mammogram to let you know that you have dense breast tissue and that there could be some complications?
So dense breast tissue is a complicated situation. We have a hard time really characterizing specifically women's breast density until we do a mammogram. We really only know what your breast density is until a mammogram is taken. And even then, there isn't always agreement between radiologists is exactly how dense your breasts are. There's not really a quantitative way to measure the breast density. And so there are areas that can be completely fatty replaced, and then there can be areas that are extremely dense. And is that woman dense or is that woman fatty? It's very hard to know. And so I think because of that inherent difficulty with figuring out whether you've got dense breasts or not, we have challenges associated with that. And so we do overall give an assessment of the breast density, but it may not reflect the difficulties that we necessarily have in interpreting the examination.
Yeah, Wendy, that's really a great question. And Sarah, maybe you can talk a little bit about legislation that is sort of marching across the country right now to answer Wendy's question. I believe it's probably both, certainly the primary care doctors getting the results back in writing if the primary care doctor ordered the mammograms as an example, or I as a breast surgeon certainly tell patients they've got dense breast tissue. But what's your knowledge about the legislations that have been adopted in Texas, California, other states, perhaps even pending in Illinois, about who should tell the patient they have dense breasts?
Well, certainly there has been legislation, and the concept is to let the patients know what their breast density is. Again, because we only know that after the woman has had a mammogram. And so in some states, there is legislation requiring the radiologist to incorporate into their letter that goes out to the patient after the examination has been interpreted as to their breast density. It can get challenging because patients will be given this information and not know what to do with it. So the responsibility is really upon all physicians of the patient, so both the referring physician as well as the radiologist, to educate patients. And that's part of our hope, is by having Google Hangouts such as this, is to educate people what does breast density mean, and then once the patients have a fundamental understanding of what that means, then we can more accurately describe what their breast density is first.
Yeah, that's a good point. The reports I get right now sort of indicate percentages, and maybe you can comment on that, Sarah. Greater than 70% or less than 30%. Has there been at the American College of Radiology any a sort of unified way of reporting breast density, or is that something that's in progress, if you will?
It's definitely in progress. Again, it's very complicated because on a 2D mammogram, you're looking at tissue superimposition. So it's kind of hard to know whether it's not a volumetric measurement. So again, it can be challenging to really accurately measure breast density, and that's why we're struggling with this. If this were easy to do, then we would have done it a long time ago.
There you go. Yeah, and we also know, Wendy, that the more dense the breasts are, not only is it more difficult to potentially diagnose breast cancer, but there's also an increased risk of breast cancer, and why that's the case we don't know. But let's jump ahead, because Sarah, the main reason we've got you here, and by the way, thank you very much for being here, is to talk about your publication in the recent issue of the Journal of the American Medical Association. Can you highlight for our audience what the study was, why you did it, and what the key findings are?
So 3D mammography was FDA approved over 3 years ago, and there have been smaller single-site studies showing that 3D mammography picks up more breast cancers and has fewer false positives, or fewer people have to come back for additional imaging that's unnecessary. So we as a group, this 13 radiologists got together, and we wanted to combine our results across the U.S. and show statistical significance how tomosynthesis works when used in combination with the standard 2D mammogram.
And so, this is all being, I don't mean to interrupt, but this is all being done for screening now. We're not talking diagnostic. This is to try and enhance screening, if you will, correct?
Correct. So we do use 3D mammography in a diagnostic setting, sure. But our study was strictly evaluating screening mammograms, and we wanted to find out whether we truly were picking up more cancers and calling fewer people back. So that was our goal. And we had nearly 500,000 examinations that we included in the study. So large representation of patients across the country, different sites, academic, community practices, different levels of expertise of the radiologists, and we published our results.
And what's been the reaction to your publication?
It's gotten a lot of attention. We definitely got a lot of interviews, and we're happy because we really want to spread the word about the benefits of the 3D mammography. It's a very exciting time.
Now, if I remember correctly from your results, you actually found an increase in the invasive breast cancers, but if I also remember, the in situ breast cancer increased detection didn't go up very much. Do you want to explain to our audience why that might be the case?
So in situ cancers are the early breast cancers, the cancers that have not broken outside the milk duct, whereas the invasive cancers are the ones that have broken outside the milk duct. And the belief is that the invasive cancers are the ones that we really worry about. There's a lot of debate in the literature about how concerning the in situ cancers are. But we found an increase in detection of those invasive cancers, the ones that potentially can spread to the rest of the body. So there has been some criticism of mammography, the standard mammography, that we're picking up cancers that potentially are not life-threatening or clinically insignificant. And so this study showed that we really just picked up the cancers that we worry about.
Boy, you just touched on a raw nerve for me, and that is the whole subject.
That was my question, too.
Yeah, the whole subject of overdiagnosis of breast cancer. Good grief. Now, in fairness, Sarah, we know that at the biology level, there are all sorts of gradations of breast cancer, from probably so benign that maybe, in fact, we don't need to do anything about it, all the way over to the super aggressives. But how do you handle the question of overdiagnosis? Because if you told a patient, oh gosh, we overdiagnosed your breast cancer, what do you think her reaction would be?
Well, it's obviously something that we all are very concerned about. The problem is that we can't tell at the time of diagnosis which are the ones are concerning and which are not. And so it would be really nice to be able to further characterize these cancers and predict which ones are going to be concerning and which ones are not. So, of course, I'm biased. I'm a radiologist, but my belief is that we really need to focus on molecular characteristics of these lesions that will really help us and then help us guide treatment. Maybe some of these cancers do not need to be removed. Maybe some of them do not need radiation or chemotherapy. But that doesn't mean that we should throw out mammography altogether and just not look.
Boy, I'm with you all the way. You said the key words for me. My vision in the future is, particularly with the in situ breast cancers, that we'll get a core biopsy, we'll do a molecular profile, and then decide at that point, based on the molecular profile, what we're going to do. My dear friend Shelley Wong at Duke, I think, has proposed such a study in situ breast cancer, that maybe all we have to do with in situ breast cancers is A, nothing, or B, to do anti-hormone therapy. Wendy, you're sitting there bouncing around. Sound like you had a question for
well,
Dr. Frida as well, huh?
I was grateful that Dr. Frida Wald addressed what the studies, concern about overdiagnosing and too many women being called back for unnecessary treatment or results. Also, I'm thinking about, how does an MRI compare to 3D mammography?
So there are really three different ways of looking at the breast. We have mammography, we have ultrasound, and we have MRI, and they all have their strengths and weaknesses. If one of those tests were perfect, then we wouldn't need the other tests. So again, they really work together, and they have different characteristics that help guide us as to where we need to evaluate further. So MRI of the three is the most sensitive, meaning that we're likely to pick up invasive cancers on the MRI more than the other tests. The problem with MRI is that we also pick up benign or non-cancer findings, and we can't really tell the difference. So it's like a very fine sieve, and we pick up all of these things on the MRI, and then we have to further investigate each of those abnormalities to find out which ones are the problem areas. So it exposes the patient. It's kind of like opening up Pandora's box. We start looking, and the more we find, the more we have to do, and a lot of it is unnecessary. But again, prospectively, we can't tell what's concerning or not. So there's a lot of reluctance to expose everybody to MRIs when we have such a hard time figuring out these areas. But again, it's the most sensitive test. Comparing the 3D mammography and MRI, the 3D mammography really is still a mammogram, and so it's still going to play upon the strength of mammography rather than looking at areas of increased blood flow, which we can't see on a mammogram. So they're really two different tests.
Wendy, does that answer your question okay?
It does answer my question. And also, I know for me, with my health insurance coverage, I carried a very large deductible. So every time I was sent to the diagnostic center, I knew that this, a lot of the fees were going to be coming out of pocket before my actual insurance kicked in. How does the whole 3D mammography work with insurance plans? Do most insurance plans cover this for patients, or are patients denied because of their lack of coverage?
It's totally variable across the country, and I think that's part of our frustration because we can't necessarily give an answer. It's not only variable across the country, but it's variable across different insurance plans, and even within the same company it may be different. So we really can't predict who's going to pay and who's not. We're really hoping that the insurance companies now have enough information to properly reimburse and make this test more available to everybody.
Now, is 3D mammography, if someone were paying out of pocket, more expensive than the standard 2D?
So it is, because it actually takes the radiologist 2 to 3 times as long as you to interpret the examination. Sometimes, depending on the size of the breast, there may be 150 extra pictures we have to look at. So wow. It is time well spent. But I think there'll be slow adoption of the technology until we can justify the expense associated with it.
Yeah, Wendy, it's sort of like, using Sarah's analogy, are you looking at the cover of the book from 2 places, or are you thumbing through the book? Obviously, it takes longer to thumb through the book. Mm-hmm. Sarah, how about CAD system development for 3D? Are we
We're not.
Are we there yet? Are people working on that?
What is CAD?
CAD is a computer-aided detection. It's a computer that helps highlight areas in the breast that may or may not be suspicious, and it's just another tool that the radiologists use. It is being used experimentally in Europe, etc. It's not FDA approved here, so we do not have the capability here yet.
Yeah, actually, Wendy, CAD, computer-aided detection, has been around for quite a while with 2D mammography, standard, even analog. CAD was around, I believe, for analog, and then switched over to digital as well. Sarah, what did you think of the accompanying editorial with your article? One of the concerns, or one of the issues or concerns they raised is that just one type of system was being used. I believe you were using the Hologic system for your study. Is that correct?
Correct. Hologic has the only FDA-approved device, so we were limited to Hologic devices. They're currently, that was the case during our study and still is the case. So I am eager to see other manufacturers' devices so we can see how they compare. But yes, we only use one device.
Yep, and any of the, I mean, obviously you've read the accompanying editorial since you were the lead author of your wonderful article. Any other thoughts or comments you have about the accompanying editorial and some of the points they made there?
Well, certainly we looked at the patient population rather than each individual patient's age or breast density, and so we need to dive deeper into the data to figure out, are there subpopulations of patients that may benefit more than others? And we do need to do long-term studies to see if there's a survival benefit. So I'm certainly in agreement with some of those comments.
Yeah, now ACRIN, you can tell our audience what the acronym ACRIN stands for. I think it's the American College of Radiology Imaging Network. Right. ACRIN, if you will, using those initials, has done wonderful studies in the past looking at breast ultrasound, mammography. Is there an ACRIN study being planned or in progress right now for a tomosynthesis?
So I'm not part of that planning committee, but I think there is definitely an effort headed in that direction, and funding is trying to be gathered.
Yep. Yep. Now, we've had also here at Breast Cancer Answers some really wonderful Google Hangouts with people like Laszlo Tabar. Laszlo's been a big fan of our site and has contributed just wonderful things. Robert Smith from the American Cancer Society has been on with us a few times. Sarah, here's your opportunity. Give us your 2 cents about screening mammography in general. I mean, my goodness, with the Canadian study and all the other controversies out there, and plus, before we came on air, you and I were talking about a recent report that talks about doing mammography in women now 75 and older, screening mammography, and 75 or over. So here's your moment. Tell us what your thoughts are.
Well, mammography is politically charged. There's certainly a lot of discussions about it for and against. But I think overwhelmingly we have seen most studies, except for the Canadian study, show that there is a survival benefit with screening mammography. So I really believe that screening mammography helps. It's not just the improved treatments, which is what the Swiss medical board suggested, that maybe it was just all the treatments that are improving survival and it's not the screening. And the Canadian study showed that there was no increase in survival. Some of the criticisms are that the mammography is not what we have today, and particularly now with tomosynthesis, we really have a different playing field now. So it's hard to evaluate computers back in the 1980s. You know, we can imagine that the technology in just computers has improved, and so the technology with mammography has improved as well. And that's what's inherently difficult about doing long 25-year studies, because we keep on improving in the interim. So I really believe that there's a survival benefit. I think it's very important that women are proactive about their breast care. And the United States Preventative Services Task Force, which is the USPSTF, they put out a statement in 2009 saying that screening should be done every other year beginning at age 50. but they are reevaluating that now and will come out with recommendations from what I understand in 2015. So the American Cancer Society has stuck with annual screening beginning at age 40, and those are the guidelines that we follow, and I think most breast imagers believe that, if not all. And we are going to follow the American Cancer Society guidelines until somebody convinces us otherwise.
And do you want to comment about the recent report about age 75 and older? We've talked to Robert Smith about that very subject, as a matter of fact, and I'm in complete agreement with him. Basically, he's saying, look, if women are healthy enough to be able to have surgery or treatments that they may need, we should keep on screening, whether they're 75 or 85 for that matter. But you want to comment about that recent report about the 75-year-olds?
Well, the concern is that the cancers that develop in older women are not going to be very aggressive. The aggressive cancers tend to be more likely in younger women. And so are we picking up cancers that are clinically insignificant, that the patients will die of other problems before they die of their breast cancer? But I have to say I'm in agreement. Just because you shouldn't be discriminated against if you're older than 75, and I think it's important that women get screened. Now, if we can improve our, again, molecular profiling of these types of cancers, we'll have a better idea of which ones to treat. Maybe some of these cancers just need medical therapy, not surgical therapy, or I'm not really sure. But again, just closing your eyes doesn't necessarily help us, I think.
Oh, I love what you just said. I'm with you all the way. And actually, I tell patients it's very similar to prostate cancer in men. There are certainly prostate cancers in men that wakeful watching can work, et cetera, et cetera. However, I've also lost track here recently, Sarah, of the number of triple negative and HER2 new positive breast cancers I've seen in older women. And I got to tell you, from a treatment perspective, that is really a dilemma. And so I don't want people to think, oh gosh, because you're older, A, you don't need mammograms, and B, oh gosh, if you get it anyway, don't worry about it, because that's not necessarily the case. Well, Sarah, it's been an absolute delight having you with us.
One more question.
Wendy's got one more question. All right.
I just need to hold space for the younger population, because screening is, by guidelines, told that it starts at age 40. And for women that are under age 40, that have dense breast tissue and that are higher risk, how do you go about educating them through the screening and to keep track of what's happening in their body?
Well, so if family history is an important question. We need to know what the patient's first-degree relatives, what their history is in terms of breast cancer. So we recommend that women who've had a first-degree relative of breast cancer, that those women get screened 10 years prior to when their family member was diagnosed. So if a patient's mom was diagnosed at age 40, then they should start getting screened at age 30. So we obviously need to make sure this is well known with the OBGYNs, so that they're the ones seeing those patients on a regular basis, and try to get those patients screened. But I agree with you. I think more and more, and this is anecdotal, but I think we're seeing more and more younger women develop breast cancer, and we're going to have to change the algorithm that's keeping in time with what's happening in the world.
Yeah, I agree with that completely. And Wendy, there's also other technologies being worked on that we haven't talked about here. There's near-infrared light imaging technology being worked on in major universities, including here, the University of California, Irvine, that may have applicability. There's nuclear medicine imaging. Our concerns there are radiation exposure, but there's more happening. I think I agree with Sarah. The family history part is important. I think, as we've talked about here at Breast Cancer Answers, knowing the lay of your own land, if you will, knowing your breast topography. Wendy, in your case, you found the lump.
I found it.
Negative mammograms. And you were smart enough to follow it through a menstrual cycle or so, and then move on it from there. And even the follow-up mammograms were negative, but the ultrasound nailed the diagnosis. So I think being aware of your body, being aware of your family history, I've never ceased to be amazed through my now 30 years of focus on breast cancer, the number of women who don't even touch their breasts are crying out loud. So, you know, all of this is part of our passion, Sarah, at Breast Cancer Answers, is educating people and through education, empowering them. Wendy, any final thoughts before we sign off?
I'm great. Thank you so much, both of you, for sharing the information to our audience and to help educate and really bring awareness so people can help activate their inner physician.
Okay. Well, she's Dr. Sarah Friedewald from Illinois. Sarah, it's been an absolute delight to meet you today. Thank you very much for being with us.
Well, I'm honored, and thank you so much for having me.
You bet. And let us say to our watching audience, thank you for being here. We apologize for about the 15-minute delay we had in getting up and going. That's a two-drink story, but we got it solved. This was a really important Google Hangout. Please join us again in the future right here at Breast Cancer Answers. Have a great day.